by the end of this section on cystic ovarian disease, you should be able to explain why it occurs in cattle, what the clinical symptoms are, and how would you go about treating the condition. Cystic ovarian disease is characterised by the presence of a follicle, at least one follicle that's more than 2.5 centimetres in diameter on the ovary of cows, in the absence of a corpus luteum. That's the classical definition. The cysts can occur on one ovary or both ovaries at the same time. What is the cause of the condition? The usual cause of the condition is an inadequate development of a pre-ovulatory surge of luteinizing hormone, and this results in a failure of ovulation, and this can be caused by a number of factors. One of the problems with an inadequate surge of luteinizing hormone is that there's an insignificant stimulus to induce ovulation to occur. Now this can result from a number of physiological reasons. If, for example, there was a lesion within the hypothalamus, or some sort of dysfunction that resulted in a reduced sensitivity to estradiol during the follicular phase, this could lead to an inadequate preovulatory LH surge. You'll remember that during the proestrus, rising concentrations of estrogen will stimulate the surge centre to release a surge release pattern of gonadotrophin releasing hormone. This surge release of GnRH will then cause a large surge release of luteinizing hormone. If the hypothalamus has reduced sensitivity to that increase in concentrations of estrogen during proestrus, then it may not respond with a preovulatory surge of GnRH, and this might lead to either no LH surge or a LH surge that is lower in magnitude than normal. The result of being a lack of a sufficiently large LH surge is that the follicle may not ovulate. And if this occurs, then the cells lining the follicle can continue to produce hormones, and the follicle can increase in size. And this cyst-like ovarian structure usually persists on the ovaries for an extended period of time, and this is usually more than 10 days, and it can be in the order of a number of months. The condition is quite common, particularly in dairy cows, where up to 5 to 30% of a herd following calving may experience a period of time where they develop cystic follicles. Cows that are producing lots of milk and are being fed a high concentrate diet are more susceptible to cystic ovarian disease, as well as there are a number of other predisposing factors as well. As mentioned, it's not an uncommon finding, and it may be part of the normal transition in some cows from anestrus, that is not ovulating, to undergoing regular estrus cycles when they're ovulating. The problem for producers is that when it occurs during the breeding season and the cows are not ovulating, then the cows can't get pregnant, and so by the time they do start ovulating, then that will be some way down the track, and so it will mean that there will be a delay in conception. And so this is one reason why they can be an economic loss to farmers. This particular photo shows you two ovaries attached to the uterus of a cow, and large ovarian follicles, a little bit larger than what you would normally get in the ovary of a cow. And these are thin-walled, and they contain a lot of fluid, and you can feel these when you palpate them per rectum as being quite large, and in this case they're thin-walled. They're most common in the early postpartum period when the cows are experiencing the most severe negative energy balance following calving. More than one cyst can occur on cow's ovaries at the same time, either two on one ovary, or a number on one ovary, or one on one and one on another, or multiple on both ovaries. But sometimes you only get one cyst. Some of the clinical signs that are associated with cystic ovarian disease. The most common clinical sign is probably anestrus, that the cows don't actually show any signs of coming in heat, and this can be one of the reasons farmers ask vets to look at them. Other symptoms include nymphomania, where the cows actually are in heat a lot more often than what you would expect. So the farmer might say, well, that cow's been in heat every day for the last 3 days, or she was in heat 2 or 3 days ago and now she's back in heat again, and she keeps doing that. Sometimes it will be erratic, so they're in heat for a little while, 5-6 days later they're back in heat again. So there's some sort of change in the normal pattern of estrus behaviour. So instead of estrus cycles occurring every approximately 18 to 24 days in cows, the cow's either not cycling, so there's no signs of estrus, or she's showing prolonged periods of estrus or erratic estrus behaviour. Some days she's on, some days she's off. In some cases where they've been cystic for a long period of time, they can develop what's called a sterility hump. This is due to a chronic exposure of high concentrations of estrogen, and you get relaxation of the sacrosciatic ligaments in the sacrum, and you get a more prominent appearing sacrum and base of the tail. And I'll show you a picture of this shortly, and that's associated with chronic exposure to estrogen. The other finding is that when the cows show up as being not pregnant on a routine herd pregnancy test, and sometimes when you're testing them you find out that they're not pregnant, but also that there's a cystic follicle present on one of the ovaries. One of the characteristic findings though of cystic follicles is that the ovarian follicle is larger than 2.5 centimeters in diameter, and usually there's the absence of a corpus luteum. There are two types of cystic follicles, some what we call thin-walled. This is a picture here of a thin-walled cystic follicle, or thick-walled, and this is a thick-walled cystic follicle. Both of these are taken with an ultrasound machine. In the case of thin-walled follicles, systemic concentrations of progesterone will be low, less than 1 nanogram per mil. When you feel the follicle, the wall will be quite thin, and you feel like it feels like it wants to burst underneath your fingers. Or they'll be thick-walled, in which case the systemic concentrations of progesterone are high, that is, they'll be greater than 1 nanogram per mil. And what's happened in these cases is the theca and granulosa cells that line the follicle have become luteinized. That is, they've transitioned from estrogen and progesterone and androgen producing cells into progesterone producing cells, and we see that as an increase in the thickness to the wall. So these cystic follicles in this case will be producing progesterone. Now I should say on palpation sometimes it's difficult to differentiate these as being thin or thick wall just by feel. So really hormone testing with progesterone is the best way to work out whether they're producing high or low concentrations of progesterone. But in practice this is virtually never done, just because it adds to the cost, and it delays the diagnosis as well. So people just usually go ahead and treat them. This is again an ultrasound image from a cow with a follicular cyst, or maybe 2 follicular cysts. This one's probably over 25 millimeters. This one here is certainly larger, so there's 2 follicular cysts on this ovary. They're thin-walled. This one, you can see the thickness of the wall, it's become luteinized. You can see these hyperechoic lines in the center of the follicle. These are associated with organization of that follicle as it develops some tissue within that follicle. It may be some fibrin or just bits of fibrous tissue that are starting to develop. This is some more pictures. This is again the large follicle structure associated with a cyst. This is the oviduct, I should say, and what we call hydrosalpinx. So there's an increase in the amount of fluid in the fallopian tube or the oviduct, and that's probably associated with an excess production of estrogen from this follicle here. If we were to open the follicle up, we see it is thin-walled on the inside. Again, you can see this a little bit of the oviduct here that's enlarged. And on ultrasound you see hypoechoic, so a dark black image because it's not reflecting much ultrasound, and then a thin wall around the outside that is reflecting more ultrasound, so it appears white in consistency. This is another picture just showing your enlarged fluid-filled ovarian follicle, large enough to be a cyst. And again, when you ultrasound it, you can't tell this by looking at this, but you can see that it's actually made up of a couple of cystic follicles. Either that, or you've got a wall or some point of demarcation between the two, but it's more likely to be two follicles in this particular situation here. Luteinization of the follicles, you find that the wall of the follicle becomes thicker, and you can see the change in colour here to the more characteristic colour of a corpus luteum as those thecal and granulosa cells differentiate into corpus luteum producing cells. Associated with that differentiation, they now produce progesterone, and this is why systemic concentrations of progesterone are high in cows with luteinized follicles. This is just a close-up to show you that thicker wall of a luteinized cystic follicle. This is a picture of the sterility hump in these cows. You can see a very prominent base of the tail and sacrum here, associated with chronic exposure to elevated concentrations of estrogen and relaxation of the sacrosciatic ligaments, and so you get some dropping and sagging in this position and a more prominent tail head here. So sometimes you can look at these cows from a distance and say, well, I wonder if that cow's a cystic cow because she has a sterility hump. How do we diagnose cystic ovarian disease? Well, they'll have a history of infertility, anestrus, irregular cycles, prolonged estrus, or delayed conception. So they may have one or more of these symptoms. On rectal palpation or ultrasound, you'll recognise a follicle that's larger than 2.5 centimetres in diameter. We can classify them as follicular cysts, being thin-walled, where progesterone is less than 1 nanogram per mil, or they'll be luteinized and thicker walled, and progesterone will be greater than 1 nanogram per mil in peripheral blood samples. Behavioural signs are variable. Again, they can be anestrus, erratic, nymphomaniacs, etc. Most situations, they're just cows within the herd that are not getting pregnant or the farmer hasn't seen in heat. How do we treat them? In some cases, there's if they're not treated, then most cases will spontaneously recover. And these are cases that occur within the first 45 or so days post-calving. The further you go from calving, that is, if you get beyond 45, 50 days, the longer they've been cystic for, the harder it is for them to recover from the condition. And it also means that if you treat them, you're less likely to get a positive response to treatment the longer they've had the condition. If there's any particular stresses in the environment of the cow, if they're being malnourished, then you should provide them with an adequate diet, as this may be exacerbating their failure to develop a pre-ovulatory LH surge. In the old days, people used to rupture them by hand, just burst them by putting pressure on the follicles. This is not recommended because there's a risk of adhesions developing over the site where the follicles have ruptured. Sometimes when you palpate them, just by accident, they happen to pop anyway, and there's nothing you can do about that. If they are luteinized, if they're producing progesterone, then you can induce luteolysis with prostaglandin F2 alpha, provided that there's enough corpus luteum, there's enough PGF2 alpha receptors present on the luteal cells. And this may or may not occur, particularly if the granulosa cells have degenerated and you've got a predominance of thecal cells, then these may lack prostaglandin receptors and you may not get a response to treatment with prostaglandin. In practice, you don't really know whether they're luteinized or not, so often we'll just treat them by inducing an LH surge and trying to luteinize them, even whether they're luteinized or not. So we can induce an LH surge independent of the hypothalamus by injecting the cows with gonadotrophin releasing hormone or human chorionic gonadotrophin, which acts like LH. GnRH will stimulate an LH surge, and HCG will act like LH and stimulate ovulation or luteinization. So this is the most common treatment. Treatment with GnRH is the most common treatment, although HCG is used, but it's a little bit more expensive, so it's not used as much. Another supplemental treatment that can be used is you can treat the cows with progesterone over like a week or so, and this is usually done with a form of a CEDA or a Q-mate device. The advantage of this is that that progesterone treatment may help to restore the sensitivity of the hypothalamus to estrogen, and so the positive feedback effect of estrogen during proestrus is more likely to induce a surge release of GnRH and LH. In more refractory cases or difficult cases that don't respond to simply GnRH treatment, we may treat them with a combination of treatment. For example, we may treat them with the OVSYNC protocol, we may treat them with a CEDA or progesterone releasing intravaginal device, plus induce ovulation with GnRH or HCG, and then we might try to synchronize ovulation by, after 7 days of treatment with the CEDA, inject them with prostaglandin, and then induce them to ovulate again with GnRH or HCG. You could also use estrogen to try to induce ovulation as well, although in these cases I think it's probably preferable to use GnRH or HCG, as you're not quite sure how sensitive that hypothalamus will be to estrogen. You do get some cases that are chronically cystic, that is for the rest of their lives, that they just are persistently cystic cows, and these are very difficult to treat. And in such cases, the fact that they're refractory to treatment, for example, you can induce ovulation, but as soon as you get luteolysis, they just revert to their cystic state again. Some of these cases, perhaps they have a lesion within the hypothalamus, which means that they cannot produce a surge release of GnRH, and this perhaps could happen the fact that they're chronically producing a lot of estrogen, and this down regulates the estrogen receptors within the hypothalamus. So even though in the presence of estrogen from the follicle, it fails to induce a GnRH surge because the estrogen receptors have been down regulated. Sometimes cows that have been repeatedly superovulated as embryo donor cows, sometimes these develop chronic cystic ovarian disease, and perhaps it's because they've been overexposed to estrogen, and this has caused downregulation of the hypothalamus, or perhaps some sort of lesion has occurred within the hypothalamus that prevents it from functioning normally. We're not really sure, but there's certainly cases that are refractory to these treatments that I've mentioned above. So that gives you a bit of an outline of cystic ovarian disease. Some review questions for you to consider, so I suggested you pause the video at the moment and just spend some time reviewing some of these questions. We'll just look at the first question. Cows affected by cystic ovarian disease commonly display which one of the following clinical signs? Anestrus, nervous signs such as aggression, regular onset of estrus without ovulation about every 21 days, and have ovarian follicles 15 to 20 millimeters in diameter. Cows affected with cystic ovarian disease commonly display anestrus as a clinical sign. They usually don't show aggression. They usually show erratic estrus behaviour and cyclicity, and follicles are usually larger than 25 millimeters in diameter. So this is the common sign that they show. Let's look at the second question. Cystic ovarian disease can reduce reproductive performance in dairy herds. Define what is meant by the term cystic ovarian disease and how it can reduce reproductive performance in herds. Well, cystic ovarian disease is characterized by a follicle greater than 2.5 centimeters on one or more ovaries of a cow, usually in the absence of a corpus luteum. How can it reduce reproductive performance in herds? It reduces reproductive performance in herds by delaying ovulation in cows, and this delays conception from occurring. Another problem that it can occur, if the cows show erratic estrus behaviour, then farmers may inseminate them a number of times, and of course they'll fail to get pregnant, so this can be a cause of semen wastage as well. How do cystic follicles develop in cows, and what are the range of clinical signs that can be evident in cows with cystic ovarian follicles? Well, the primary problem with the development of cystic ovarian disease is a failure of an adequate preovulatory LH surge. So the LH surge either doesn't occur, or the magnitude of the surge is too small to induce ovulation. And the factors that can cause this are that during proestrus, or in the face of rising concentrations of estrogen, that rise in concentration of estrogen fails to induce a surge release of GnRH from the hypothalamus, and therefore you don't get an adequate LH surge from the anterior pituitary gland, and therefore ovulation doesn't occur. What causes this failure of the hypothalamus to respond? Maybe the hypothalamus has a reduced sensitivity to estradiol, and this might be associated with things such as negative energy balance. So that's one of the reasons why we commonly see it in the early postpartum period, because this is when the cows are experiencing quite a bit of negative energy balance. How can cystic follicles be treated? Well, the main focus of our treatment is to actually provide an adequate stimulus for ovulation, and this can occur through administration of drugs such as GnRH, which induce an LH surge of normal magnitude, or we can administer drugs such as HCG, human chorionic gonadotrophin, which act like luteinizing hormone and would help to induce ovulation or luteinization of the follicle. If the follicles have been luteinized, then some of them occasionally will respond to prostaglandin and undergo luteolysis. But that's not the preferred method of treatment. More chronic cases, you may treat them with a combination of treatments, such as initially induce ovulation with GnRH or HCG, treat them with progesterone via a CEDA or a Cumate for 7 or more days. At the end of that period, remove the CEDA, inject prostaglandin to induce luteolysis, allow the animal a couple of days for that growing follicle to start to get up to preovulatory size, and then force ovulate them with another injection of GnRH or HCG, and then artificially inseminate them just after you inject that drug to induce ovulation. So approximately 16 hours after administering the drug to induce ovulation. And some cows will be chronically cystic, and these are much more difficult to treat. So that gives you a review of some of the factors causing some of the symptoms and causes of cystic ovarian disease and how you might treat it. Which one of the following hormonal treatments is used to treat cystic ovarian disease? The main drug there that we use is gonadotrophin releasing hormone, because we know that this will induce a preovulatory LH surge. ECG in the cow acts more like FSH, so it's not used to treat cystic ovarian disease. Estradiol benzoate, theoretically it might be useful because you can induce an LH surge provided that the hypothalamus is responsive. However, we don't know in a lot of these cystic cows that the hypothalamus will have a reduced sensitivity to estradiol, so I think it's better to use something such as gonadotrophin releasing hormone. FSH, we've already talked about that it wouldn't generally be used to for cystic ovarian disease, because it's going to increase follicular development, and what we want to do is induce ovulation. Cortisone, well, cortisone is inhibitory of luteinizing hormone, so it wouldn't be wise to use to administer cortisone. how would the following treatment be helpful in a dairy cow with cystic ovarian disease at 70 days postpartum? Well, 70 days postpartum, that means that the cow has a reduced chance of recovery because she's been cystic for quite a while, possibly. Doesn't mean she won't recover, but it means that she'll be harder to treat than a cow that's, say, 30 days postpartum. By injecting GnRH, we'll hopefully induce a surge release of luteinizing hormone from the pituitary gland and induce ovulation or luteinization of the cystic follicle. This will increase concentrations of progesterone, but we can also treat with progesterone as well via a CEDAR device. And hopefully this chronic treatment with progesterone will increase the sensitivity of the hypothalamus to estradiol, so the hypothalamus is more likely to respond with a surge release of GnRH when estrogen concentrations rise. Now, of course, we've induced ovulation here, so we need to get rid of that corpus luteum or luteinized follicle, so we're administering prostaglandin here, and we're allowing the cow to go effectively into proestrus. So during proestrus we'll be getting a rise in estrogen, the follicle will be getting bigger, the new follicle that's arisen after we've treated here. Then when this new follicle is large enough, we'll give them an injection of GnRH and try to force ovulate them, and then we'll inseminate them approximately 16 hours after giving this injection of GnRH, just prior to when they're due to ovulate. And that's one combination treatment we could use to treat cystic ovarian disease. So this brings us to an end for this section on cystic ovarian disease in cattle.